Good morning and welcome to my YouTube channel again. Today's talk is about the basics of arterial cannulation. Only I'm going to talk about the techniques in a simple way and probably some sort of troubleshooting. And visit me at www.painfreepartha.com for slides and painfreepartha for YouTube channel. And what was the history like in this thing? In Stephen Hales in 1714, see the first cannulation. In 1848, surgical cut down, this 1953, and now lakhs of arterial cannulations or catheterizations are happening daily. Now I am very clear. This is indications of arterial cannulation. It may be blood pressure monitoring. It may be frequent blood classes. It may be PPV and SPV contour analysis. Non-invasive blood pressure monitoring with large surface area. We don't have this thing. Then we can have arterial cannulation. We don't have place to check BP like that. So these are all the indications of arterial cannulation. When to insert an artery. If you want to go into the other eye, it may be used for hemodynamic monitoring. It may be used for blood sampling. It may be useful for interventional procedure. Put the radial artery and put in stenting, cardiac output monitoring. These are all the indications if you look at the other eye. Hemodynamic monitoring, blood sampling, interventional procedures, and cardiac output monitoring. Maybe this will come slightly to this point. While when you should not cannulate, it is very important then what are the indications? Absence of collateral circulation. There is a local infection. Distorted anatomy here. You may go in for other. Active Raynaud's disease. Burns, aneurysms. There is a stent here, vascular graft. AV malformations. They have put a renal AV fistula for here, CRF. So these are all the contraindications. If you don't have a collateral circulation, if you have an infection, distorted anatomy, if you have an AV graft, if you have an aneurysm, Raynaud's disease, all these things point out to contraindications of arterial cannulation. Yes, coagulopathy, severe thrombocytopenia. Recently, we have used thrombolytics. Relative contraindications. Which arteries are preferred? Radial artery, then femoral, then dorsalis, brachial, ulnar artery, axillary artery, and superficial temporal artery. So which artery means radial, femoral. Then only all others come. Why should we choose one like this site? It should be large. It is somewhat proximal to the heart. I will come to the why it should be proximal and what are the problems of distal in a separate video of setting up an analysis of arterial waveforms. It should have good collateral circulation. It should be comfortable for the patient. If you put it here in the elbow, it may not be very comfortable. It should be accessible for the nurses. Unaffected by infection and trauma. Not in the way of any other planned procedure. For example, you are putting an arterial cannulation for a purpose of CABG and we are going to take a radial artery graft. So it should not be interfering with this. Preferably close to the monitoring equipment. So should have comfortable to the patient, easy for the nurse, no infection, no trauma, no planned procedure. It should be somewhat proximal to the heart, but it should be also large. What are the catheters used? Fluorinated ethylene propylene, FEP catheters, PVP catheters. Now you see the area of the radial artery is 3.8 square millimeters. A 20G cannula may be 1.6 to 1.7. A 22 is only 0.62. Think of here and here. That is the problem if you put a 22 in a radial artery. Now you see, ideally, at least 3.5 centimeters should be in. Okay. and 15 to 17 centimeters should be in the radial artery and in the femoral artery. If we don't have that, then it is a problem. The waveforms analysis may be different. So this is what is important. See here 3.8, and if you're 22 gauge, maybe 0.66. Innumerable equipments, you can have on-off switches, you can have cannulas, you can have cell tinker methods. So many, rarely you can use normal well flows. Now you have to check for collateral circulation. Now you see site is fine, no infection. Then position, gloves, yes, these are all the testing. Then we can go to this.
The radial ulnar, she is doing the blanching. Yes. One more blanching. Yes. Done. Okay. Wait. I'm just releasing the ulnar. And within 5 seconds, everything is becoming red. Okay.
So this is the classical modified Allen's test, where you see the ulnar collateral is excellent. If you have an ulnar collateral good, yes, we can prick the radial artery. The artery should be compressed proximal to the expected tip of the arterial catheter. Now your tip will be here. Proximal to it will compress because proximal branches of the radial artery to the hand circulation could elicit, because now you are compressing here. But your arterial cannula is going proximally to that. Then what is the purpose? So whenever you compress, you should compress in a place where the site is proximal to the tip of the cannula. Now you see, probably the radial artery may be pricked here and the end will stop here. Now I am compressing here. This is what is the, and after that, you put a probe here. The artery is well seen here. This is one test to see, yes, possibly there are good collaterals. Now this is Barbour test. Apply both pressure to the arteries, pulse oximeter in the radial thumb, and release the ulnar artery. And see now, it's very simple.
You can see the pulse oximeter. Now I am not compressing any vessels. I am just pressing both the vessels. Now you can see all the pulse oximeter is gone. Now I am releasing the ulnar. Okay.
At the proximal flexor crease of the wrist, 1 centimeter to the proximal to the styloid process. Now you see, this is the 1 centimeter proximal to the styloid process at the level of the crease. A little proximal is difficult to puncture. If you go little more proximal here, sometimes the radial artery may be deeper, difficult to puncture, but the artery stays straight, so it may be easier to cannulate. Now you see site of prick is depicted, proximal crease, styloid process 1 centimeter. Now we can see the artery in the cross section also.
The process, we need to prick here around from there up little proximal here. Okay. Now what we have to do is we have to palpate the vessel and then remove it and check whether it is better here or better here or better here. Even if you feel very well, you just check this side and that side. Don't do like this. Don't do like this. Put it. If you are not feeling good, then check it here. Which way you are comfortable and the pulse is of good volume.
Now the actual technique is sterile ground gaze table with linen equipment, position, clean drape, local without adrenaline, minimal, and angiocath 30 degrees, put it inside, blood gush, decrease to 15 degrees and inside the cannula. Now you can go see here. Better to have a stool, and there is some good towels in our thigh, because sometimes the gush will go and push it in our sterile gown or something like that. That should be thick enough. So it will go inside our normal disposable sterile gowns. Give a local prick cannula insertion, suture, transparent plaster, and tubes. Sometimes you can give cocktail, verapamil, nitroglycerins, and heparin. Now, when accessing the femoral artery, the patient is in supine position with the hip chosen slightly externally rotated. And the artery should be palpated between the pubic tubercle and the anterior superior iliac spine. You palpate the femoral artery. Make it, sometimes if in a scan, distally you can see two arteries. And go proximally above towards the abdomen. You will see the common femoral artery. Then you have to prick. Brachial artery, yes, one study of 3, 4, 5, 8 patients. They have found out not much time, even it is okay for 7 days. You just prick here, but the only problem is it is patient's comfort is little less. Why not ulnar artery? We have told break first radial, then brachial, then this thing. Femoral and then brachial. Ulnar artery is bigger in the forearm, and it is smaller, while radial artery is bigger here. Removal of radial artery is probably the same, better than the ulnar artery. Now, dorsalis pedis collateral flow is excellent. Cannulation is also easy. Minimal patient inconvenience, very low incidence. But the problem is the BP may not be very accurate because we go distal, the systolic is high, the diastolic is low. Why? I will come with the next video. Now you see, some people keep this thing very high, and this is 30 degrees. You come down and then cannulate, towel here, and this should be closed. Vessel becomes superficial, flattened, and lateralized on extension. If you extend, the artery will become superficial, but more flattened. So we should be thinking of the difficulty in cannulation. So we are palpated here. Now if you do the extension, it will become lateralized. Now you see the artery here.
அப்படியே வச்சுக்கோ இங்கே காட்டு
கையில் கட்டு.
Now the artery is punctured with a hollow needle, and we can have a wire, and then this is different technique, Seldinger. So we can cannulate the artery like this also. So also possible is transfixation technique. See the artery, get the gush, go, and then slowly come out, and then put the cannula. If the guide wire doesn't go near the artery, but in vein, catching on the arterial intima, we have created a false passage. Chosen an artery which has got a scenic route. There is an excessive erythema. The artery has developed vasospasm because of multiple stabbings. These are all the common things. That is why we can put slightly local without adrenaline to decrease the vasospasm. We have created a false passage. Remedial measures, clear blood flow, transfixation techniques, a flexible tip, smaller cannula, change the bevel angle like this, and use ultrasound. Ultrasound guidance has been demonstrated to increase the success rate, but what they have told is it is better and more proficient for good practitioners who are already proficient in the palpation methods. But this study is 2006. Another study is, yes, there is an increased chances of radial artery cannulations. The learning curve of number of procedures, you see here, around 25 to 30 cannulations we are here. There is not much difference. Not carefully determine the exact center of the pulse. Sliding your finger we should not do. Put the finger, palpate, get up and put it again. Take up and put it again this side, medial, lateral. which is good volume, which is very good volume and easily palpable. Then you go in that side. Slide, no. Lift and reposition. If the artery is not entered, when the needle has reached the appropriators, do not tick, 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 do not do. Remove and then go. Don't manipulate in the depth. The needle do not manipulate in the during cardiopulmonary arrest, other conditions of low BP, that is where we want arterial cannula. Okay? The arterial blood may be dark. It is not pulsatile. Difficulty in shock. It is very difficult in atrial fibrillation because it is irregular. One pulse is coming good, another pulse is not coming good. I will tell you two things. In mitral stenosis, the volume is fixed and low. It doesn't change much during these things. So if you insert the radial artery, it is difficult, but cannulation may be easy. In mitral regurgitation, artery will be like this, prick is okay, but at the time you start cannulating, the vessel may be like collapsing like this, so it may be difficult. So pricking also should be careful and should be inside the vessel in completely the center of vessel in regurgitant lesions. Avoid pushing too hard on the artery while palpating the pulse. May compress the artery. Some arterial lines are sensitive to wrist positions. The wrist may be immobilized in a most satisfactory position. Yes, even after you position it, you can do an ultrasound scan where it is quite big like. The radial artery may be 1 millimeter. Yes, this is very important. That is why if you do an extension, then lateralized. That is why best palpation, it is 1 millimeter medial. But if we do an extension, it comes little laterally. You are in 30-degree prick and decrease the angle. Instead, we can go directly at 20 degrees and fix it. Do not insert the guide wire on the first gush. Should be extreme dexterity of the hands. Superficial radial artery that crosses over the tendons, defining the anatomical snuff box of the wrist. Duplication of the artery, absence of vessels, tortuous radials. Sometimes veins are superficial, which is the biggest headache. Sometimes the artery, see here, the vein is going proximally like this. Vein is going here superficially where you prick exactly. Ultrasound guided peripheral arterial cannulation, priority, not an option. The most common complications from radial artery catheterization when performed by anesthetist are temporary artery occlusion. Artery is occluded part, some hematoma, some bleeding. You just give a compression. Mostly it is nothing. Infection, bacteremia are very less likely. In cath lab, the complications are less because they often use heparin. If rapid local swelling, don't bother. Don't bother. Remove the needle and put the gauze mask. Press it for 10 minutes, but don't press it so much. There is complete blanching here. See that out. If you are failed to cannulate and if the radial pulse is felt well, then you go proximally. There is no pulse, no cannulation of radial and even ulnar on that side. Better to go for femoral or other side. So very important. If you have punctured the radials, when the radial pulse is felt, then you can go proximally. If the radial pulse is not felt, then don't go ulnar also. Don't go proximal radial also. Go to other side or femoral. To reduce the risk of catheter-related infections, not more than 7 days. Catheters should be removed as soon as possible. They are no longer needed. There is no need. Remove the catheter. Not to use the stopcock, very important. During removal, after it has done the job. Apply tight dressing, and sometimes special balloons are available, and keep a pulse oximeter. When you remove, always keep a pulse oximeter in the thumb, and then see whether the vascular is there. Now, which arteries? Hemodynamic monitoring, repeated blood gases, interventions, cardiac output monitoring. These are the indications. Which arteries? Radial is first, femoral is two. Then only comes brachial, dorsal is contraindications. There is an AV fistula, distorted anatomy, thromboangiitis obliterans. Beware. Techniques: simply radial artery, put an extension, palpate it, and then prick at 30 degrees, come down and insert the cannula. If you cannot get transfix, go beyond the radial artery, come out slowly with dexterity, and then insert the cannula. And then slightly rotate also. Complications: mostly hematoma, some bleeding, infections are rare. Yes, we know tips and tricks I've already told. And thank you all and welcome to my YouTube channel, Pain Free Partha.